Hello everyone. In this class, we'll learn about thyroid gland. The two principal hormones secreted by thyroid gland are thyroxine and triiodothyronine. They are called as T4 and T3 respectively. Small amount of reverse T3 also found, which is in inactive form. T3 is more active than T4. Peripheral cells of thyroid gland secretes calcitonin, a calcium lowering hormone. The thyroid gland is composed of large number of follicles. Each follicle is lined with cuboidal epithelial cells, which are called as thyroid cells, and filled with a secretory substance called as colloid. When gland is inactive, the colloid is abundant, the follicles are large, and the cells lining them are flat. When the gland is active, the follicles are small, the cells are cuboid or columnar, and the edge of the colloid is scalloped, forming many small reabsorption lacunae. This diagram showing the inactive and active form of thyroid gland. In inactive, when the thyroid cells are flat and colloid is abundant, when they are active, the the thyroid cells they become columnar or cuboidal, and the colloid becomes less in number. Synthesis of thyroid hormones. Iodine and tyrosine are essential for the formation of thyroid hormones. Iodine consumed through diet is converted into iodide and is absorbed from GIT. Tyrosine is also consumed through the diet. Stages in the synthesis of thyroid hormone. The first step is thyroglobulin synthesis. The endoplasmic reticulum and Golgi apparatus in the thyroid cells synthesize and secrete glycoprotein molecules called as thyroglobulin into the colloid. It contains 123 tyrosine residues that combines with iodine to form thyroid hormones. The hormone remain bound to thyroglobulin until it is secreted. Then there is a step of iodine trapping. The iodine trapping is the picking up of iodide by the thyroid gland. Sodium and iodide are co-transported into the thyroid gland, and sodium is pumped into the interstitium by sodium potassium ATPase, which is also called a secondary active transport mechanism by which the gradient for sodium is created. The next step is oxidation of iodide. The uh, iodide has to be oxidized to iodine because only iodine is capable of combining with tyrosine. The process of oxidation is promoted by an enzyme thyroid peroxidase, where the hydrogen peroxide accepts the electron. Then the next step is iodination of tyrosine. The binding of iodine with thyroglobulin molecule is called as organification of thyroglobulin. Tyrosine of thyroglobulin is the first iodinated to form monoiodotyrosine, that is MIT. Then MIT is next iodinated at the fifth position to diiodotyrosine, which is called as DIT. So then coupling reaction occurs where DIT combines with MI2 to form triiodotyrosine, that is T3, and two diiodotyrosine combine or couple to form tetraiodotyrosine, or it is called as T4 or thyroxine. The enzyme peroxidase is required for coupling reaction. Note that MIT and DIT can also lead to reverse T3. So these are the steps of formation of thyroid hormones. The first process is formation of thyroglobulin from endoplasmic reticulum and from the Golgi apparatus. The thyroglobulin then secreted into the colloid, and there the colloid matter is iodinated, and then it is going to form MIT and DIT. So there will be coupling of these MIT and DIT, and the thyroid hormones which are combined with thyroglobulin, they are released into the colloid, which are picked up into the thyroid cells, and they are secreted back into the carriage. In combination with thyroglobulins, thyroid hormone can be stored in follicles for several months. Therefore, when synthesis of thyroid hormones ceases, the physiological effects of deficiency are not observed for several months. Release of thyroid hormones. Thyroglobulin itself is not released into the bloodstream. The hormone are first cleaved from thyroglobulin. The process occurs as follows. The apical surface of the thyroid cells sends out pseudopods like extension that close around the small portion of colloid to form pinacocytic vesicles. These vesicles then enter the thyroid cell. Then the lysosomes of the cell fuses with the vesicles. The digestive enzymes present in the lysosomes digest thyroglobulin and release T3 and T4 in free form. These then diffuses through the base of the thyroid cells into the surrounding capillaries. The T3 and T4 secretion, or rather T4 to T3 secretion ratio is around 10:1. The transport of T3 and T4 over 99% of T3 and T4 combines with immediately with the plasma proteins like thyroxine binding globulin and thyroxine binding prealbumin and albumin to lesser extent. The rest circulate in unbound form in the plasma. These are some of the difference between T4 and T3. T4 is considered as a precursor of T3 and is solely secreted by the gland, whereas T3 is considered as physiologically active form, and plasma T3 comes from deiodination of T4 in the tissue and secretion by the gland. T4 combines less freely with the DNA receptor, whereas T3 has a more affinity to the receptor on the DNA. T4, the amount secreted is 10 to 20 times more, whereas the amount secreted T3 is less. T4 is more bound to protein and less in less free form, and T3 is less bound to protein and it is more in free form. T4 is slow and sustained action, whereas T3 has a fast action. Some of the actions of these thyroid hormones: metabolic functions. They have a calorigenic action. The thyroid hormone in general stimulates the metabolic activity and increases oxygen consumption and heat production in most tissues of the body except in brain, testis, uterus, lymph nodes, spleen, and antirespiratory. Thus, it increases the BMR. They increase the activity of sodium potassium ATPase. Their effects on carbohydrate metabolism: increased uptake of glucose occurs by the cells. They enhances the gluconeogenesis and increase the rate and absorption of from the GIT and the increased insulin secretion. So, effect on the fat metabolism: mobilization of the fat from the adipose tissue occurs because of the under the influence of thyroid hormones. There will be increased levels of free fatty acid levels. There will be enhanced oxidation of free fatty acids by cells. There will be lowering of the circulating cholesterol levels due to the increased secretion of cholesterol in bile, and cholesterol secretion is increased by inducing the formation of LDL receptors in the liver, resulting in increased hepatic removal of the cholesterol. Plasma levels of triglycerides and phospholipids are also decreased. Effects on the protein metabolism: in physiological amounts, thyroid hormones function as anabolic hormone. They cause increase in RNA and protein synthesis. In high concentration, they have catabolic effect. The effect on vitamin metabolism: thyroid hormones increase the quantity of enzymes. Vitamins are essential part of some enzymes and coenzymes. Therefore, thyroid hormone causes increased need for vitamins, leading to relative vitamin deficiency in hyperthyroidism. The role in growth and development. Their effects on the growth: thyroid hormones are essential for normal growth and skeletal maturation. They exert their effect directly by increasing protein synthesis and enzymes, and indirectly by increasing production of growth hormone and potentiating their effect on the tissues. They also promote growth and development of brain during fetal life. for the first few years of postnatal life. Their effect on other endocrine glands, they increases the rate of secretion of other endocrine glands, and also they increase the uh, need of tissues for hormones like insulin, parathyroid, and catecholamines. Their effect on the body weight, greatly increased thyroid hormone always decreases the body weight, and greatly decreased hormone almost increases the body weight. Then there are systemic effects like cardiovascular effects on, they increase the heart rate, they increases the stroke volume, uh, and they increases the cardiac output. Cardiac output is increased due to the increase in metabolism, increase in the beta adrenergic receptors both in number and affinity, and also increase in the level of alpha MHC, that is myosin heavy chain. Uh, Then their effect on the blood vessels. Systolic blood pressure is increased due to the increase in the cardiac output, and diastolic blood pressure is decreased due to the peripheral vasodilatation. Vasodilatation is due to increase in the heat production and increased metabolites. This results into the increased pulse pressure and increased velocity of blood flow, causing increased circulation, that is, which is also called as hyperdynamic circulation. Some of the respiratory effects they lead to increase in the rate of metabolism, increases the utilization of oxygen and formation of carbon dioxide. These affects the activity of all the mechanisms that increase the rate and depth of respiration. Their effect on GIT, they increase the appetite and food intake. Thyroid hormones also increases secretions and motility of the GI tract. Their effect on the central nervous system, they are essential for brain development, especially the cortex, basal ganglia, and cochlea during fetal life and for the first few years of postnatal life. Normal functioning of brain need thyroid hormone. The hyperthyroid individuals may develop psychoneurotic problems like anxiety, complexes, extreme worry, etc. Reaction time of stretch reflex is shortened in hyperthyroidism and it is prolonged in hypothyroidism. Thyroid hormones are essential for normal formation of synapses and myelination in the developing brain. In hypothyroidism, there will be abnormal development of synapses, decreased myelination, and decreased growth and branching of dendrites. This decrease in number of neurons is responsible for mental retardation. Their effect on skeletal muscles. Slight increase in the thyroid hormone can make muscle to work with more vigor, but excessive secretion causes weakness in muscles due to the catabolism of proteins. Fine muscle tremor is a characteristic sign of hyperthyroidism. Effects on the sleep. Hypersecretion of thyroid hormones causes excessive stimulation of the muscles and central nervous system. So the person feels tired, but because of the excitable effects of thyroid hormones on the synapses, it is difficult to sleep. On the other hand, hyposecretion causes excessive sleep, that is somnolence. Effect on reproductive system. For normal function, thyroid hormones are essential for normal reproductive function. In males, lack causes loss of libido, and excess causes impotence. In females, lack of these hormones causes menorrhagia, that is excessive bleeding, and polymenorrhea, that is frequent menstruation, and hypersecretion of thyroid in human causes oligomenorrhea or reduced bleeding. Regulation of secretion of thyroid hormones. The secretion of thyroid hormone is regulated by the negative feedback mechanism through hypothalamus anterior pituitary thyroid gland axis. There is also autoregulation of thyroid in the thyroid gland itself. The secretion of thyroid gland is regulated by food iodine contents. If there is a deficiency of iodine content in the diet, then the iodine trapping mechanism of the thyroid cells becomes super efficient, and vice versa if there is excess of iodine content in the diet. In this way, iodine availability for thyroid hormone synthesis remains constant, and this phenomenon is called as autoregulation. So this is the negative feedback mechanism. how the thyroid hormone secretion is regulated. Hypothalamus produces thyroid regulating hormone, which increases the thyroid hormone stimulating hormone from anterior pituitary, and so the T3 and T4 they are produced, they in turn negatively inhibits the anterior pituitary and the hypothalamus by negative feedback mechanism. In normal individuals, large doses of iodine act directly on the thyroid to produce mild and transient inhibition of organic binding of iodide and hence of hormone synthesis. This is known as Wolff-Chaikov's effect. Antithyroid drugs that depresses thyroid secretion, they are called as antithyroid drugs. Mechanisms, they mainly act by interfering iodide trapping and by blocking the organic binding of iodine, for example, thiocyanates, propyl thiouracil, and high concentration of inorganic iodides. Thiocyanates ions, they decrease iodide trapping, and administration of thiocyanate in high concentration causes competitive inhibition of iodide transport into the cell. That is, thiocyanate and iodine ions have the same active pump. Propyl thiouracil decreases thyroid hormone function. It prevents formation of thyroid hormone from iodides and tyrosine. Mechanism, they block the peroxidase enzyme required for iodination of tyrosine and partly block the coupling of two iodinated tyrosines to form thyroxine and triiodothyronine. Iodides of high concentration decrease thyroid activity and thyroid gland size. When iodides are present in high concentration, most activities of thyroid gland are decreased to reduce rate of iodine trapping. So the rate of iodination of tyrosine to form thyroid hormones are decreased. Some of the thyroid function tests to assess the function of thyroid gland are the sleeping pulse rate. So if it is more than 100, it is seen in hyperthyroidism. BMR normal basal metabolic rate ranges between 37 to 40 kilocalories per meter square of body surface area per hour. BMR increased in hyperthyroidism and decreased in hypothyroidism less than 50 and 20 respectively. Serum cholesterol levels increases in hypothyroidism and decreases in hyperthyroidism. Serum T3 and T4 estimated radio amino acid levels are normally T3 is 0.15 micrograms per deciliter and T4 is 8 micrograms per deciliter. Ankle jerk, that is Achilles reaction time, normally it is 2 to 3 milliseconds. In hypothyroidism it is prolonged and in hyperthyroidism it is shortened. Radioiodine uptake studies, that is iodine 131 is given orally in 100 ml of water and thyroid uptake is determined by placing X-ray counter over the neck. Normally it is 20 to 40% is taken up. Then by scanning technique, by thyroid biopsy to detect the malignant processes, then TRH or TSH stimulation tests also done to know whether pituitary or it is thyroid gland disorder. Some of the applied aspects related to the thyroid gland, hypothyroidism. It is caused by low levels of circulating thyroid hormones. Depending on the cause, it can be primary hypothyroidism or secondary hypothyroidism. Primary hypothyroidism is a disorder of thyroid gland, whereas secondary hypothyroidism, where it is secondary to the disease of anterior pituitary or hypothalamus. It leads to myxedema in adults and cretinism in children. Cretinism. The cause for cretinism can be congenital absence of thyroid gland, or there can be genetic disorder or lack of B12. The symptoms of cretinism are, they usually appear 1 to 3rd week after the birth. They appear idiotic, ugly, obese, and short child. Mental retardation is common in them, and All the milestones of development are delayed. The skeletal growth is more affected than soft tissue, so stunted body with a pot belly occurs. Tongue is larger, which is called as macroglossia, and protrude out of the mouth. Big tongue obstructs swallowing and breathing. Sexual development is affected. Skin is dry, coarse, and wrinkled. Hair is sparse and scanty. Temperature is subnormal in them. So this is how a cretin looks, where the musculoskeletal growth retards. There will be pot belly, frontal bossing, and the child is mentally retarded. Treatment is treatment of the neonate with cretinism at any time with adequate iodine or thyroxine returns normal physical growth. But unless the cretinism is treated within few weeks after birth, mental growth remains permanently retarded. Myxedema. The myxedema occurs in hypothyroidism in adults. General features of myxedema are tiredness, weight gain, intolerance to cold, mental sluggishness, poor memory, decreased BMR, lower body temperature, husky and slow voice, and hair are coarse and sparse, and they will have extreme sleep. Some of the cardiovascular disturbances are like adrenergic activity is decreased, causing bradycardia, atherosclerosis due to the increased cholesterol levels, and atherosclerosis increases the blood pressure. Some of the neuromuscular features like fatigue, stretch reflex reaction time is prolonged. Some dermatological features like where skin becomes dry, yellowish, that is keratonemia occurs since conversion of vitamin A require T3 and T4. There will be swelling of the face, puffiness under the eyes, and non-pitting type of edema. Reproductive manifestations will be usually menorrhagia and infertility, and there will be constipation and anemia as well. So these are some of the clinical features of myxedema, that is periorbital edema, dry skin, coarse hairs, and puffy face. Hyperthyroidism. Its common cause are Graves' disease, toxic goiter, TSH secreting tumors from anterior pituitary, and mutations that causes activation of TSH receptors. Some of the symptoms of hyperthyroidism are there will be intolerance to the heat, increased sweating, weight loss, nervousness, muscle weakness, extreme fatigue but inability to sleep, diarrhea, tremors of hands, goiter, atrial fibrillation, tachycardia, and exophthalmos. Treatment for hyperthyroidism is usually surgical removal of the thyroid gland. Graves' disease is an autoimmune disease and is characterized by development of TSH receptors stimulating antibodies. These antibodies bind to TSH receptors and mimic TSH action, making the gland hyperactive. In Graves' disease, there is a marked stimulation of secretion of thyroid hormones and high circulating T4 and T3 levels. This will inhibit TSH secretion. Increased levels of thyroid hormones tend to cause increased formation of antibodies, and exophthalmos is often seen. Exophthalmos means protrusion of eyeballs. The cause of protruding eyes is edematous swelling of retroorbital tissues and degenerative changes in the extraocular muscles. Sometimes eyeball protrusion stretches the optic nerve enough to damage the vision. Due to the protrusion of the eyeball, the eyelids cannot be closed completely while blinking or sleep. So constant exposure of eyeball to atmosphere causes dryness of cornea, leading to irritation and infection, finally resulting ulceration of the cornea. So this is diagram showing the exophthalmos, that is protrusion of the eyeball. Goiter. Goiter refers to any abnormal increase in the size of thyroid gland. Goiter does not denote functional state of the thyroid gland. It may be associated with euthyroid, hypothyroid, or hyperthyroidism. Any anti-thyroid substances that cause enlargement are called as goitrogens. Goitrogens decrease thyroid hormone synthesis, leading to feedback increase in the TSH secretion. TSH is responsible for the formation of hypertrophic thyroid gland, that is goiter. Goiter in hyperthyroidism is called as toxic goiter. And goiter in hypothyroidism are of two types: endemic colloid goiter, or it may be due to the deficiency of iodine, or it may be idiopathic non-toxic colloid goiter. Endemic colloid goiter, it is also called as iodine deficiency goiter, where intake of iodine is less than 10 micrograms per day. TSH is produced due to the feedback mechanism and stimulates thyroid cells to secrete tremendous amounts of thyroglobulin. Due to iodine deficiency, uh, T3 and T4 production does not occur and thyroglobulin remains as such and gets accumulated in the follicles of the gland, and this increases the size of the gland. Idiopathic non-toxic colloid goiter, enlargement of the thyroid gland, occurs even without iodine deficiency. Some of the causes are thyroiditis, abnormal enzyme system, goitrogen substances like propyl thiouracil present in the turnips and cabbages. So this is in brief about thyroid gland. Thank you.